He has authored 8 books, published 200 plus research papers, led national and international projects on cognition, aging, stress, and mental health. His work has earned him some of the most prestigious recognition in the field, including Best Performance Awards by Indian School Psychology Association, ISMA Research Award. Today, at IMHS 3.0, Dr. Reddy joins us to help answer a powerful question. Are we prepared clinically, ethically, and emotionally for India's aging future? Ladies and gentlemen, psychologists, students, and mental health warrior, please put your hands together and join me in welcoming Dr. Reddy. And now it's time to introduce a true trailblazer in the world of elder care and cognitive health. Please welcome Tanvi Malia. Please give it up for Tanvi Malia. All right. Neuropsychologist and founder of TMECS, Tanvi Malia's Elders Care Services, India's first and leading organization dedicated to providing specialized psychological support for older adults and their families. Tanvi works at the front lines of dementia, Alzheimer's, stroke, and Parkinson's care, bringing evidence-based neuropsychology into Indian homes, hospitals, and caregiving systems. Beyond clinical work, we also support older adults experiencing depression, anxiety, and adjustment challenges with deep empathy and skills. She is also a visiting faculty at St. Xavier's College, teaching neurocognitive interventions, caregiver counseling, and lifespan-focused mental health, shaping the next generation of psychologists. And she's not stopping there. Tanvi is now developing India's first certified course in Geriatric, soon to launch in collaboration with leading universities. Since 2014, she has been a fierce advocate for healthy aging, dementia awareness, and caregiving support. And her pioneering work has been featured widely in the media and honored with several awards. Her mission is clear. Aging should not mean decline. It should mean dignity. IMHS family, please put your hands together for Tanvi Malia. Our next panelist is someone who turned a personal crisis into one of India's most impactful elder care movement. Please welcome Prasad Bhide. He is the founder and CEO of Aaji Care Home Health Services Private Limited and co-founder of OWL, Older, Wiser, Livelier. Back in 2012, Prasad had everything many dream of, a successful IT career in the US, security, stability. But when his mother was discharged from ICU, he faced a harsh reality. Finding skilled, compassionate elder care in India was almost impossible. That changed everything for him. If his family struggled, what about millions of others? So Prasad did something bold. He walked away from his corporate life and returned to India to build the solution himself. Today, Aaji Care and OWL have become Mumbai's most trusted elder care ecosystem, offering trained caregivers, assisted living, medical support, and most importantly, dignity, connection, and companionship for aging adults. His work isn't just healthcare, it's humanity. Please join me in giving him a huge round of applause to the visionary transforming Prasad Bhide. Our next speaker brings both world-class clinical expertise and deep personal heart into his work. Please welcome Dr. Aditya Andhagar. He's a cognitive neurologist with specialized training in dementia care from the University of Calgary, Canada. Dr. Andhagar isn't just someone who studies dementia, he's someone who has seen the emotional weight it puts on families up close. That personal experience shaped his mission and led him to return to India to serve where support is most needed. Today, he works at the intersection of science, compassion, and advocacy, addressing not just the condition, but the lived experience of the person and the caregivers. His work reminds us treating dementia isn't only about memory, it's about connection, community, and again, dignity. Please give a warm IMHS welcome to Dr. Aditya Andhagar. We have another speaker for this panel. someone who's transforming dementia care and aging support in India with fierce passion and world-class expertise. Please welcome Amrita Patil Pimple, founder of Echoing Healthy Aging. It's an organization that is dedicated to bringing dignity, compassion, and evidence-based care to older adults and their families. Amrita brings over a decade of international experience in geriatric psychology and dementia care. She has worked as a researcher at the University of Northampton, UK, and is a certified trainer in person-centered dementia care, and from both the Universities of Bradford and the University of Stirling. She has trained NHS staff in England, designed specialized care programs, and contributed to international research on dementia support. Her impact has been recognized globally with awards including Business World 40 Under 40 in Healthcare Excellence, UN Women Asia Pacific Care Accelerator Grant recipient, Goldman Sachs 10K Women Entrepreneur, named among the top 50 social enterprises in Asia by DBS Foundation, UN Ltd India Social Entrepreneur Award. From research to policy to community care, Amrita is bringing a future where aging is not feared but supported. Please give a warm, warm welcome of IMHS to Amrita Patil Pimple. And now, guiding this powerful and much needed conversation on the future of geriatric psychology is a woman who has been with IMHS not just as a collaborator, but as a believer, a backbone, and a constant support of the mission. Please put your hands together for Gitika Dubey. She is the advisor and mentor to IMHS and the creative mind behind Rapturous Minds, our gifting and community partner. Gitika is a biomedical engineer with MTech from VIT Bangalore and currently serves as visiting faculty at IIP Indore and Miranda House. Her work beautifully blends science, psychology, and creativity. Through Rapturous Minds, she has built India's first cognitive wellness puzzle platform, designing jigsaw puzzles as a mind gym to strengthen memory, problem solving, critical thinking, and slow cognitive decline. Her puzzles are now used by adults, wellness platform organizations, and entering geriatric and rehabilitation spaces across India. She has also created a growing community through national puzzle tournaments, making brain health engaging, social, and joyful. Her journey represents everything IMHS stands for: innovation, accessibility, and heart-driven mental health action. Mumbai, please help me welcome the brilliant, the thoughtful, and deeply committed Gitika Dubey.
Thank you so much for that introduction. That's quite heavy to live up to. I mean, hello, everybody. Before I can shoot the questions here, how many of y'all are really interested in geriatric care? Oh, that's quite a number. Are you sure? Because it's not easy. It's really not easy. And let's start having the conversation. Am I audible to everybody? Perfect. So the first question, it's a multi-billion-dollar industry, and I hope that's not the only motive to start all the startups in this segment. I've come across many people who've just started in this segment because it's a multi-billion-dollar industry right now. But money aside, this is a segment that really requires enough attention right now. We are aging at a very fast pace, and not in a very good way, I would say. We are very unaware population for that matter. We don't understand the process of normal aging. Forget about dementia and other neurocognitive decline and other neurodegenerative disorders. So the first question is for Tanvi. For those who are new to the field, what exactly is geropsychology, and how is it different from general psychology or working with younger people?
If you ask me in terms of education, it's different in India because we have no specialized neuropsychology training. So I think a lot of what training the psychologists go through is probably, I think a lot more people who are studying neuropsychology for their masters will maybe have a little more than what people who are studying clinical psychology or counseling psychology will have. But very often what I've noticed while also designing and going through curriculums is that it's just very often a checkbox in your curriculum. You know, there isn't specialized training. Of course, it's changing. With Xavier's, we've already, you know, that change has come through, and I see with a lot more programs across the country that's changing. But in terms of training, I think that would be the biggest, sort of challenge that we see. Interestingly, I'll tell you this. 2 years ago, we ran an informal survey just to find out how many psychologists work with elderly across the country. And I'm not even using the word specialized. I'm just saying that within their practice, work with people over the age of 50. Geetika, we had 20 people that even work with elderly across the country. So we're not prepared to support the aging population at all. You know, in terms of practicality, or when it actually comes to the application, I think one of the biggest challenges that psychologists have is to unlearn a lot of what is thought is effective with the other demographics. So what would almost be sometimes unethical in working with other demographics is a necessity while working with older adults here. You know, when you're working with older adults, I feel that even amongst a lot of individuals that work with older adults, say in a dementia care setting or whatever else, it cannot be so clinical, because the minute you make it very, oh, we have to do A, B, C, you are somewhere not dignifying the person that exists beneath it. So I feel that psychological practices, mental health practices that focus on older adults need to kind of fill that gap, because we're not working only with a symptom, right? We're working with an individual who has lived 60, 70, 80, 90 years and is now showing certain symptoms. So how do you kind of cater to that? And I think coming to the family, the bigger challenge is that, you know, as a community, we don't have that understanding yet. And that understanding is what we need to build on, you know. So more power to anybody, and I think pretty much everybody on the stage is very big on advocacy. So more power to anybody, all of you who choose to speak about older adult mental health, about these specifics. You know, please do this, because this is a conversation that doesn't receive a lot of attention, a lot of participation, even in the mental health spaces. So thank you for taking this up for the panel itself.
That's wonderfully put. I'll just add quickly. Very oddly, in last 2 months, I must have had about 18 people just called me, friends and families, and discuss about how to deal with my parents. They have crossed 60. There's a change in behavior. They are erratic. They are not listening. They are bantering. They are throwing things. They are becoming miser, which they were never before. Suddenly there is an urgency to save money and not spend even $2 on something very important. So it's very hard for me to explain them that this is a part of normal aging. I mean, there's no diagnosis like really over here. It's normal aging. So what is happening here is the one who's aging is not aware of the process of aging. The one who's taking care of is also not aware of the process of aging. And within couples also, the pace of aging is very different. Like in my case, my mom and dad, my mother has been diabetic for 15 years. Her pace of aging is very different. She is already slowed down, and my father is not slowing down. So for them to have a communication amongst themselves is also becoming a challenge, because he's unable to understand that she was able to pick up 5-6 instructions 1 year back. What is wrong with her right now? Why she's not able to pick up 5-6 instructions? Because she's slowed down. So this awareness, this segment where we begin to talk about, at least talk about, such things is extremely important. Thank you so much for that input. So the question is for you. Much of the cognitive aging research is Western. We do not have longitudinal study in India, not at all. I think NIMHANS is just starting the longitudinal study. So what cultural, grounded behavioral or cognitive markers do you believe Indian geropsychologists must integrate into as a part of their tools and formulations while dealing with geriatric population?
Thank you for that question. I think before answering that question, just I want to add you the previous question. So up to now, the psychology, when you're applying a psychology, bombarded more on, deficit, more on the problems and the symptoms, and the syndromes. Now I think we need to see little differently after the positive psychology, how the positive psychology can be applied in a geriatrics where This can be maybe connected to the cognition or maybe that specific age. How well the person can enjoy that period of, that's how this land used to be, the culture. You see that in a family system, whenever we know that our grandparents is going to be retired, entire grandchildren and the family used to be, excited. They're going to be with us. We are going to listen to, the stories and all those things. That is one thing. Another thing, you see that the biomedical model more focusing on, the physical, more the neuronal. I think now we need to look into the, it's like a general health checkup for their cognition health. We need to focus more on, healthy aging and the prevention instead of, the more. I think all youngsters, I think whoever want to be the geriatrics, I want to see that more, where you can work with the community and the family system, you can work towards the prevention of this problem. In one way, we are celebrating, we're excited, we are a young country, entire world is seeing us to grow with us. At the same time, you see the problems they're facing now, Germany and Japan. Once upon a time, they're top leaders. Now they're suffering with this. Now I think we need to learn from them and we need to prepare well. I think for you, especially after maybe 10, 20 years, we are going to come in their stage. So what I'm trying to say here, don't see that the geropsychology or geriatric psychology only, this is something related to the problem. You need to work, in a same weightage, even the prevention, where we can keep the good cognitive health. The second question, what you mentioned that, so in one way it's a good, we have a good literature. We are learning very well with the Western approach, understanding, assessment, even a diagnosis and all the treatment model. This, it won't work just like that in India. We are different. Take example, the languages. You see all the Western, at the most they can speak one language or two languages. Here, even to manage to maintain a tea shop, at least you need to know 3-4 languages. You see that. Literacy, you see that affordability. All those things is very, very, very important to us. I think you young people, what you need to see, the main thing is how well you can modify the validate to our culture. That is one thing. Another thing is very interestingly, I think we are a leader. I can proudly say that when it comes on the technology, the way we use the technology for affordability, you see that. I think we need to use this, and wherever it's possible, how, whatever we do the service, how we can make it more accessible, affordable for our population. Otherwise, you just like that, if you try to copy whatever the Western practice is doing, it's a very difficult to see that, whatever the improvement and the changes, the impact you are expecting. Thank you.
Thank you so much for that insight, sir. I'll just take 5 seconds to say that Rapturous is a startup which is also working on a similar vision. We are the first startups that working in the segment of preventive cognitive care. Why preventive cognitive care? Because as sir mentioned, that demographic dividend is going to become demographic dependent all at the same time, right? Like, I don't know how many times I must have used this statement. If any one of you are attending this for the 3rd time, here at least I have used it for the 3rd time. And we do not have the capability to bridge in the gap that is already there. So the best solution for us as a population is to start talking about preventive care. That's one of the first things. And second thing I would like to add with what sir has said is whatever solution you think of, you need to think of the solution in terms of masses and affordability, because look at the numbers that we are in. So it's very, very important that we realign all our approaches and thought for any solution, whether it is sex education, whether it is geriatric education, whether it is child education, in terms of masses. How do we penetrate through the population, the numbers that we are looking at right now? Because no matter how good each one of us are in this room, we are not going to be able to reach each one of them. So till the time we begin and drift our thought process. Thank you so much, sir, for their insight. The next question is to Dr. Aditya. In your experience, what does an ideal collaboration between a neuropsychologist and a geropsychologist look like in complex cases such as mixed or rapidly progressive dementias?
Excellent question. What I would start off by saying is it's not just in mixed dementias or complicated dementias. The first lesson that I learned after going to Canada, I trained at Jaslok and I completed my neurology there. So when I used to look at all the South Bombay doctors, and I would dream about being someone like them, like they're accomplished, they come up rolling in their flashy cars and they have a big stature and they have a lot of fellows under them. And that was kind of the dream hierarchical approach that a young trainee doctor would have had. So after going to Canada, one of the key lessons I learned is no, it has to be an egalitarian society where it's a multidisciplinary approach that can provide the best care to not just dementia, but any kind of neurodegenerative disorder or most disorders. So that was a very humbling experience when I went there, and in the memory clinic that I used to work, there used to be a psychologist, a neuropsychologist who would help us in doing the diagnostics as well as the cognitive stimulation therapy part. There would be an occupational therapist who would assess capacity and help with fall prevention as well, along with the neurologist, a psychiatrist, and we would all work together as a team to identify what are the different challenges that that family has. Because dementia is a big symptom. If you have 100 families, all of them are going to have different flavors of behavioral symptoms, cognitive symptoms, etc. So individualizing treatment in a multidisciplinary panel is the correct approach to dementia management, which I think might be currently lacking in our scenario, but working together, we can move forwards in that aspect. The second point I want to highlight is, as a neurologist or as a doctor, the time that I spend with the patient is very different in contrast to a neuropsychologist or a geropsychologist who would say be spending 1 hour on an alternate day basis with the patient, right? So if I spend half an hour, it's just 1/10 of the time that another person like the psychologist is spending with the patient. So acknowledging that and making sure that the feedback loop is well maintained so that I get subtle signs that, okay, there is improvement in the agitation symptoms, so there is improvement in the hallucinations, or there are some new symptoms which have been unmasked. And you know, that feedback that you get when you work with a team closely, that would benefit a potential client's health. So it is very important to broaden minds, and unfortunately, I'm not talking to doctors here. Had there been doctors in the audience, this message would have been well received by them, that we need to work together and collaborate together to understand how we can provide better care. So that would be my comment. I would also like to highlight that, coming back to the previous question, it is a billion-dollar industry, yes, but that doesn't mean that everyone needs to come into this space. You need to ask yourself the question, do you have the right aptitude? Is it okay if you deal with people who are agitated, who look down upon you, who would swear and abuse at you, and there's a considerable age difference. So suppose there's a 25, 26-year-old neuropsychologist doing a cognitive assessment for a 75-year-old established industrialist who's now undergoing cognitive decline. That person is, who are you to ask me these questions whether I'm oriented to time, place, and person or not? And then having the right aptitude and temperament to deal with such clientele is a different skill set. So maybe having aptitude screenings before you jump into the field of geriatric psychology is something that you should ask yourselves at the end of this talk. So I think I have answered that question. Yeah, another caveat maybe, you asked about rapidly progressive dementias. The problem here is I was trained to assess reversible and neurodegenerative causes of dementia. In Canada, out of 10 patients that I saw, 9 would come in earlier stages of, say, mild cognitive impairment, where the person is not yet dependent on a caregiver for day-to-day activities. 1 would be in an advanced stage. In the last 2 months that I've been back in India, all the patients that I've seen, 10 on 10, all have been patients who have come in an incontinent stage or agitated stage or insomnic stage, and they're all well advanced. So when I introspected and asked what's the difference between Western culture and our population of patients that I deal with, the key highlight is that our family members take up the role and mask their symptoms. So if dad is unable to pay checks, son steps in and says, I'll do it. If grandmom is not able to fix meals, the daughter-in-law is coming and fixing stuff for her. So this decline in ADL is masked by family members. So generating awareness that If you don't use it, you lose it. So don't relieve your parents and grandparents of the work that they are capable of doing. Keep them as capable as possible towards the end stages of their illness. That is the only important buffer, not the only, but a very important buffer to help increase cognitive reserve. So what I have heard the most common complaint that people ask me in the clinical setting is, doc, why now? 3 months back, he was fine. 6 months back, he was fine. You look at the scan, there's profuse atrophy. So obviously the story goes back a decade or at least 5-7 years. It's not just 3 months, 6 months. But the symptom history narrated is typically 3 to 6 months. So that in their head is a rapidly progressive dementia, where I would explain it by saying that the cognitive reserve has been eroded, you have reached the tipping point, and now you're witnessing a rapid decline. So again, working with a team of psychologists and occupational therapists would be extremely beneficial to help address caregiver burden and help complement the deficits that they're having. I think that would be my answer. Yeah.
I would just like to add, I was just reading a case study yesterday, and there was this 101-year-old woman whose autopsy was done, and her behavior-wise, there was no decline at all. But her autopsy showed that she had lots of tau proteins and classic symptoms of Alzheimer's. So she was fortunate enough to survive 101 years without showing symptoms. But there was another paper that was talking about signs begin as early as 32 and 33. The decline begins as early as that.
So maybe sorry.
Please go ahead.
Yeah, I'll just clarify that point. It's very important to understand what is healthy aging and what is abnormal. So as you mentioned, the 101-year-old lady could be harboring amyloid plaques and tau tangles in her brain, but she was still able to carry out her day-to-day activities. That implied that her synaptic cross connections were still robust enough to maintain function. So that implies that healthy aging is acceptable and is the norm. If you're unable to do that, that means there is something lingering. It's a neurodegenerative process which is driving these changes. In autosomal dominant disorders, where parents have had dementia, Alzheimer's disease, their children have had, and now their children are being enrolled into studies, the data comes from there, that when you do amyloid PET scans and tau PET scans for them serially starting at the age of 18, around 30s, 40s, you start seeing the deposition of amyloid plaques in these brains. But it's only when they reach 60s, 70s that they start manifesting symptoms. So our brain has a very big amount of cognitive reserve. To give you another analogy, we all have 2 kidneys. You donate 1 kidney, you can survive on the other kidney. When that other kidney is 90% compromised, that's when you have the first signs of uremia or vomiting. So that's the concept of reserve. The brain also has a tremendous amount of reserve. So I absolutely agree that although we don't have a silver bullet to cure Alzheimer's, the best step forward is prevention is better than cure. Increase your cognitive reserve by doing exercises, staying socially engaged, the owl phenomenon. So we need a lot of strategic partners who can work on a preventive aspect, because Indian culture is not favorable towards maintaining all these lifestyle changes which are advocated. So whatever our grandma taught us, now science is catching up to that. And I'll just, if I'm talking too much, you can stop me. I'll just give a personal anecdote and I'll stop here. So when I left for Canada, I was 96 kgs and I was overweight and I was not in the best health. After going there, I realized that exercise is the norm. You have to use public transport, walking, the cold, eating salads. I lost weight organically to 85 over 2 years. And the last 2 months, I decided that enough is enough. I was feeling homesick. I joined Dabba, Mansi's Dabba, which was a Punjabi lady serving food. And suddenly, I put on 3 kgs. Same lifestyle, everything same from 85, I come back to 88. So the problem is the hidden calories, the cashews, the butter, the everything that I had there. Then on coming back here, I made it a point that I have to continue this lifestyle. I have to ensure that I eat healthy, I exercise, and I sleep on time. And the tragedy here is my colleagues, doctors, they call me over for dinner at 12 o'clock in the midnight. That is the time that practice is over, now come for dinner. So I told them, boss, I've slept at 10:30. I'm sorry. I'm living another lifestyle now. So that made me reflect that we have all the tools required to follow a healthy lifestyle, but our society is not structured to support healthy living. So that's my comment.
Yeah, I just wanted to quickly add a few things to what Dr. Aditya said. So, prevention is very important, and catching these neurocognitive disorders, neurodegenerative disorders is very important. But because this is primarily psychologists, I also want to say that we resort to neuropsychological test batteries to catch this, right? Neuropsychological test batteries will not show decline until the person is in the early to mid stages. It's very difficult to catch, for the test to catch that decline. We don't have tests that are sensitive enough yet, right? And what your question was about the elderly whose brain was showing the plaques and tangles. This is something that we have seen through our practice in the past 11 years, where it is not just Alzheimer's, right? We also see an increasing amount of older adults in India, they show small vessel disease. So, they show changes in their vascular systems, which they may have never had blood pressure clinically, right? They may have never had diabetes, but maybe they're somewhere along those clinical ranges. The approach that we take within our practice is a biopsychosocial approach. So when a person comes to us, we actually evaluate all their comorbidities, we look at all their reports, we look at their brain scans, and this is the very reason why we do that. We've had cases where, there is some atrophy or something like that showing, but, it's not necessarily diagnosed, right? And I think while we get blood tests almost every year, I hope all of us do, right, to check for sugar and everything else. Why do we do that? Because we want to catch diabetes when it starts rather than living with it for, say, 10 years, right? So we need to kind of figure out systems wherein we get our brains also assessed regularly, because yes, obviously ensuring that you live a healthy lifestyle, eating good food, ensuring that you get workouts, and that could be a whole different conversation of what you could do. That's a part of it. But how do you stay on top of the assessments? Right? How do you take that preemptive health into account? The second point, and I'll be very quick, I wanted to address is what Dr. Aditya was saying about how do 25-year-olds deal with somebody that's older? Why will somebody that's older take somebody who's 25, 26, 30 seriously? That's where geropsychological training comes in. Right? A lot of people, and this is very unfortunate, and this is just a systemic issue that we are trying to fix as well with a lot of other people, wherein there is no specialized training. So even today, when you say cognitive stimulation in India, it literally involves a person who has been trained for 7 days, 10 days, 15 days, going to an older adult's house, doing 5 or 3 or 4, whatever, memory, puzzle, this, that, and coming back. Okay? That is not geropsychology. It is more specialized, it's more nuanced. You have to understand each individual for who they are. You have to understand their comorbidities. You have to understand their family systems. And while this is what geropsychologists do, this is also training that needs to be given to any health professional, any medical professional that works with this demographic, that works with this population. So I'm a very big believer in having this specialized training. But yeah, a lot of the challenges Dr. Aditya mentioned can be sort of resolved. We can prepare that resource, we can prepare a population of very trained geropsychologists, but we need to put those trainings in place today. So thank you. That was the point I wanted to make.
Thank you so much for that. We are running short of time, so I'll just quickly go to the next question. This is for Dr. Prasad. What psychological patterns or family interactions have most surprised you in the assisted living context, and how do they influence resident well-being?
So Aaji Care currently, both the things, we run assisted living centers currently, 5 centers in 3 cities. There are varied experience that we have seen based on the family interactions. Assisted living is a center where typically family keeps them when they care for them, right? When they feel that we are not able to care for them at home and they require more than just a family caregiving, they require a multidisciplinary care, and that's where they get admitted to the center. We have seen various different kind of interactions with the families. There are families who visits them on a daily basis. There are families who visits them on a weekly, and there are families who visits once in a quarter. One of the instances I can share, we had one gentleman staying with us, and he had 3 daughters, and they used to visit him on a regularly week-on-week basis. But what we realized, one of our psychologists realized, is that after one daughter visits him, he's not in a good mood. He will typically start showing a different way of reacting. He will start shouting on our caregivers. He will not be in a good mood for 2 days. And we've seen that for 2-3 months, and then we try to find it out, and we realized there is some issue with the property. And the daughter was trying to kind of ask father to do something on behalf. Now, that made us scary. And we changed the way we were approaching or we were allowing family to interact. So earlier it used to be a closed door discussion. We will not know what is happening inside a room once a family member visits. Now we changed that. We ask them to visit in a common area, right? So, and they are under CCTV. Now that's not really a good way, but we have seen such 2 or 3 interactions which made us scary, because these elders are vulnerable and they get scared. And especially when there are these kind of family interactions. So I think that is one of the things that I can share which has changed the way we used to work with elders and allow family interactions. But one thing I have seen very common is people who had a good family, regular family visits, either physical or through technology, are one of the most happy people. We do a survey, and one of the survey very clearly shows that people who have a regular family interactions are far happier than other seniors. Yeah.
Yeah, it's a complex issue. I mean, it's very difficult to deal with both the ends. I'll move quickly to the next question. It's for Amrita ma'am. Many nurses and care workers in India enter elder care with limited exposure to person-centric or sensitive training. What foundational psychological skills like respectful communication, validation, tone modulation, or maintaining dignity do you believe need to be prioritized from day one?
It's a very important question. And before I get into the solution, I just quickly want to explain how the serious issue is of this person-centered care. So in fact, I have one very quick question to the audience. If I say 2 minutes, just 2 minutes, what comes to your mind, right? Just very quickly, if anyone wants to answer. Sorry? Silence, yeah. Yeah. Maggie, yeah. So something very quick, right? Something very quick. So interestingly, there was a very large-scale study in UK in the elderly care homes, fairly large, I think 1,000 elderly they studied. And they saw that 2 minutes was the total interaction any elderly in the care home got in a day, right? So that 2 minutes also includes, do you want a cup of tea? Do you want to go to the washroom? Let's go for lunch, right? Let's dress you up, etc., etc. And interestingly, later they found out it was 1 hour of person-centered care, right? What Prasad was mentioning is family talking to them, even the caregivers talking about what interests the elderly. 1 hour per week actually improved their quality of life. So we were just talking about our 10 to 15 minutes of good person-centered care. And what is person-centered care? That is something not task-centered. Task-centered means you give them a cup of tea, you move on, go to the next elderly, and so on. Then you take them to the washroom, lunch, dinner. Caregivers are extremely busy, be it nurses, be it the caregivers are at home. They have a lot of tasks to be done. And many times, even families are at fault because they are always checking, are these things done or not? But when they are offering that cup of tea, can they sit down with them, just talk to them for 5-10 minutes, is what the person-centered care is. Hence, extremely important that along with lot of the medical science, the symptoms, communication, we also give them empathy about the elderly, that's stepping into their shoes. And the bigger issue here is, especially with diseases like dementia, impaired communication is part and parcel of this disease, right? So elderly is not able to communicate many times their needs, their wants. Hence, we need special kind of training, be it to nurses, caregivers, even what Tanvi mentioned, to psychologists as well, who are going, say, just for an hour to the elderly's home. But if they do not understand the person-centered care, they will not connect with them. Many times we have even physiotherapists reaching out to us who are working in the elderly care, but they say, see this particular client with dementia, we are not able to work with him. So then we train them that how to communicate with this elderly, what are the needs of this elderly, because you have just met one elderly with dementia. They have different personality, they have different biographies. Hence, for you to understand how to work with various elderlies, be it age, be it their dementia stage, you need to understand what they are feeling. Yeah, and that's where the empathy plays a big role. Hence, yes, we are a huge advocate of person-centered care, and we have seen it works very well. So the elderly we have been working with, I think we have been there with them for 5-6 years, right, till the end of their life. So you become their friend, you become their family member, in fact. So yeah, it's, I think, a very crucial part of training for all the care professionals. Yeah.
That's very interesting. And any tips on people who are not professional but taking care of their elderlies in their house? It requires a lot of
You mean
grounding.
like the family members?
Yeah, yeah.
Okay. That's again a very huge problem, unpaid care. And that's where we step in as professionals, right? We are giving them respite, right? We are trying to replace family members for an hour, for 12 hours, for 24 hours. And that can only be done if you understand what the elderly needs are. Now, in the care centers, the requirements are very different because the ratios you will see, I'm talking about what I have seen. It might be different in Prasad's center. But typically, you have one caregiver assigned to 5 elderlies in a care center. When it comes to home care, it's more than that because we also count the cleaners, the cook, etc. in the staff. So at home care, for one elderly, you have 4 to 5 people looking after them. But yet, the family caregivers feel burnt out because no matter what, the elderly wants to complain to family member. And many times, I think Tanvi also might have experienced this. Family members think, "Aap jo activity kar rahe ho na, we can also do it," right? But it doesn't work. Because moment family members is there, I can't see, I have this pain, that pain. And moment a trained geriatric psychologist comes in, okay, they want to talk to them. They want to work with them. They want to do activities with them. So yeah, I think we can only succeed in elderly care if we work not just with the elderly, but also the family members. So professionals, family carers, and the elderly, all three have to work together to get the quality of life we desire, not just for the elderly, but also for the family members. Yeah.
So profound, so profound. Thank you so much for your insight. Last and
Just to add that. I think I agree to Amrita what she said. When a psychologist goes at home, she doesn't have to just look at the elder, but more with the family members. Because family members will have a lot of questions and they feel so easy, what she said is right. I think they need to understand the aging process. I think that's where the education has to be need to be done, because they are not able to see why mom is behaving this way or my father is behaving this way. They are just not able to take it easily. I think so. There has to be a lot of psychoeducation that needs to be done to the family members.
Let me add one more point here. See, in the last month, I sent all my neuropsychology students for the internship. Is a part of the community service. When they started interacting the family members, they come up, sir, we need to do the more than, the geriatric, whoever who tells that, the equally you need to give the more importance to the caregivers. In earlier, that approach used to be very individualistic. Now, it became a family approach. Now, I think they are there with the, this population. We need to educate equally to them, even offering some sort of a certificate program to them to manage routine, that emotional issues and all those things is going to be a huge contribution. That's one thing. Other thing is we need to educate them how to take care of themselves. Taking care of this population, it's not easy. I think that also is very important, is part of community service. We need to give the importance.
Tanvi have been talking about this. I think it's time to start working on it now. Last and quick question. As India's population ages, what do you think are emerging opportunities and challenges position geropsychology to become one of the next billion-dollar frontiers in the mental health?
Is that a question to me?
Yeah.
Okay. So I think I think the biggest challenge is obviously that we do not have formalized neuropsychology training yet. So I think that would be where we start out with. Of course, we also have to address that while more and more students today are opting for psychology than what they did 25, 30 years ago, a very big part of that decision-making process is also the financial scope of what comes in, right? And the financial scope, although it is projected to be great just because of the number of people that are going to age and therefore the number of concerns that are going to show, but one big challenge to that is the lack of awareness. Right? So we have to ensure that there is awareness because like Dr. Reddy very clearly, very beautifully said, it is not only about reacting to a diagnosis, right? It is the process of aging healthier. And when do we start this? Do we start this in our 40s? Do we start this in our 50s? When do we start this? So the more people that understand about brain health, the more people understand about aging, what is normal aging, what is not normal aging, when should you raise flags, the more psychologists understand about, okay, so you may not be working with people that have dementia or other neurodegenerative condition, but say there is a client that comes to you in their 50s who's displaying some preclinical signs. So today, if you look at cognitive science, it will tell you that there are no the earliest preclinical symptom is, clinical symptom is, maybe short-term memory impairment or a visuospatial impairment, right? But through our practice, we've seen that before this, there are some emotional symptoms that precede this. Right, so we have actually been able to send families much earlier to the neurologist when this disease or the diseases are still in their preclinical stages. Right? And I think that kind of knowledge is what I honestly am working towards formalizing, because I think India really needs it. We're a land of so many cultures, we're a land of so many intersectionalities, and having, our diagnostic criterion, our, sort of understanding, our general community, country understanding of all of this is very important. And I think that burden, unfortunately or fortunately, is right now only on psychologists. Right? So I really would want a lot of other health professionals to step in, because this is going to make everybody's work easier. Just a final point that I want to make. With what Dr. Aditya said, and we were having this conversation earlier, he spoke very candidly about how the neurologist can only spend, say, like an hour with the patient, right? And I had to tell him, but it is not your labor or job to do, because that is what psychologists are there for. But this does not happen in India because everybody is working in their own silos. The neurologist is working independently, the physiotherapist is working independently, the psychologist is working independently, and eventually within my practice, we have very voluntary and happily undertaken the labor. So we very happily, when we see that they may benefit from XYZ, we very happily send them to them. But this is not a labor that should fall on psychologists alone, right? So, but understanding this, understanding your roles, where you come in, not trying to show that, oh, we do everything, I think that is very important. And I think that is a very big challenge that psychologists are going to have to deal with once they actually come into practice. So that's my response to that. I hope that answered the question.
So one last quick concluding remark.
Yeah. So I apologize on behalf of all the neurologists. That I remember one comment where I won't quote, but the doctor said that when patient starts asking too many questions, the relatives start asking too many questions, there's a referral made to a neuropsychologist to get testing done. They know by default that psychoeducation would come after that thing. But to add science to your previous statement about behavioral changes, so I was very lucky to work with a mentor called Dr. Zainur Ismail. Coincidentally, he is from an Indian descent, now settled in Canada. He is the pioneer who coined the new term mild behavioral impairment. So rather than mild cognitive impairment, mild behavioral impairment. How do you define it? Any person above the age of 50 who shows changes in their personality or behaviors, which is new, which was not their baseline before. For example, new onset depression or anxiety or apathy or hallucinations, which are persistent, lasting for more than 6 months. That is a warning sign of some neurodegenerative change happening in the brain, and is something that should trigger you to come and see a neurologist or any doctor who understands more about neurodegenerative diseases, and lifestyle changes or other precautionary measures or mitigating risk factors can be done so that the rate of decline can be reduced. So I think I'll add value to that.
One thing I will like, why it is $1 billion opportunity, right? I think that we have not spoken. I think the important point that we have to understand, we are just 10 or 11% seniors, right? With 15 crore people staying here. In next 25 years, it is going to be more than 34 crores. That means it's going to double, right? The number of challenges will increase. Number of senior living opportunities, assisted living, dementia is rapidly growing. That means the challenges are increasing. That means the opportunity is going to double or more than that, right? And that is the reason why someone can choose that as a career, because it's going to be a long-term and fulfilling career.
But to add to that,
Can I also quickly add?
We will also be on the other side of the dementia.
Absolutely.
Absolutely. We have to do
That's
this
why
for
we
us.
want people to be ready for that.
Yeah, yeah.
Just to add to Prasad's point, because even I felt that was not addressed, is see, when we entered, actually Prasad and me were incubated at the same time about a decade ago. That time the elderly care was not glamorous, now how it is. So we are purely passionate social entrepreneurs. And that time, the issue was we had less supply of professionals and more demand. And 10 years down the line, nothing has changed. Same issues, right, Prasad? And we definitely need trained workforce. But what I have seen, because we are continuously hiring a lot of psychologists, the elderly care definitely pays better, appreciates the professionals who are well trained, and you have a lot of variety. Be it the at-home services, clinic-based services, you can be in the hospitals, you can be in the assisted living, you can work with the doctors. And another thing that even in today's paper that has come out is about the gig workers, right? I personally have seen a lot of psychologists are in that zone, right? You tend to do a lot of freelancing, you tend to work with certain organizations. So a lot is changing in India in terms of what the gig workers also can achieve, and not like sort of long-term employment. So a lot of trainings when you take in geriatric care, you have those opportunity available as well, that you can work on your own, you can work with certain organizations. So definitely I'll highly encourage you all to look into the elderly care as career opportunities. It will give you everything that you desire, be it the pay, be it the satisfaction, be it the flexibility that you require. So we definitely urge you to look into geriatric care as, you know, your professional, your career, as your career aspiration as well.
Wonderful. So last.
Quickly one.
Yeah.
Yeah. In one way, I think with the technology, we are so happy, excited. You know, the technology also in future, it's going to be the risk. Take example of working memory. How many of you trying to remember your mobile numbers, other family members? Earlier, whenever any phone number if you reads, we used to think the strategy to remember. In the future, you're going to tell that even though if you try to access working memory, I don't need it when I have in a computer. Take example, second one, GPS. Whenever we visit a family members, we used to think the cues, how to remember when it comes and the next time. We're not bothered about it now. Now, I think AI, how it's going to make a difference, your prefrontal. We are excited, we are humans in evolution, we are in top, what we are going to make. We need to keep all those things in mind, yeah? So definitely whatever we predicting now, in a 2050, out of 5, you know, it's going to be going to suffer with these problems. I think you all, we need to think this also, how the technology. In other major things is the loneliness. Yeah. Now you see that when you're attending a functions, we are not interested to speak to others and share and enjoy their joy. We are more interested to only seeing the mobile, you know. So this is going to make a huge difference in future. That's what we are on and off here talking about, this specialization. It's a very, important to understand the changes. Thank you.
Thank you so much for that. We'll quickly shift to questions from the audience. I'm pretty sure Pritha is not going to let me modulate any more sessions after this. We'll take 2 questions. Okay, 3, 4. I see 4 hands. I think quickly we can probably cover everybody.
It was wonderful to raise this topic. Being an occupational therapist and clinical psychologist, as Dr. Aditya shared, I definitely feel interdisciplinary approach coming together that helps this. I just wanted to ask, like in India, we come from a strong social model where children are traditionally take care of their parents and emotionally, physically, and even financially. But this changing family structure, as we know, has been because of the work pressure and migration patterns. The need for elder care centers is increasing rapidly. In your view, any one of you can answer, why are elder care centers becoming so important in Indian context today, and what do you think future?
Yeah, I think one of the reason I feel that, as you rightly said, we are going more towards nuclear families, right? That means the family members are not available at home to provide the kind of care is required. Also, the need of assisted living is only required when there's a multidisciplinary team required. So, for example, person with dementia cannot be just taken care by caregiver, right? It will require a multidisciplinary team of a psychologist, of a doctor, sometime a nurse, based on the other conditions. So that is easily possible in the center. Second thing to look at is when a person is at home, most of the time if family member is not around, they are going to be alone, right? Feeling lonely. When they are in the center like us, they get a community where they get similar age people to talk to. When you see someone having similar issues, I think their pain reduces. If I have this issue, I'm not able to walk, and there is another gentleman who is also not able to walk, they talk about how that they can resolve, right? So I think that helps in a way. And we need to have a solution available across, which is affordable. So we need to have a solution which is possible in 10,000 rupees a month and a lakh rupees a month. I think that's where we will be gradually growing. But need is definitely there. But in India, the home care works a lot. So 90% of the people will like to go for home care as a first option. It's due to the affordability. Also, log kya kahenge if I keep my mom or dad in the center. Lot of stigma and affordability. But home care is the most prominent. Now the solutions like assisted living and senior living are coming, and they will continue to grow. But it's due to the family dynamics change.
I see increasing questions, but quickly shorten it up for the next panel.
So hi, I am. So I am a family business consultant, and I work at the intersection of family and business, where we also address a lot of conflict situation between the parents and the children when they have to pass the baton, where no succession is happening. So a lot of emotional. A lot of emotions that go into this a situation like this. How would geropsychology, how can we use geropsychology as an application in this field?
Thank you so much for that question. Very specific, very beautiful, and I love things that are specific and beautiful. I see. What happens usually in a family business is there is an intergenerational participation eventually, right? Like there is somebody who's 30s or maybe late 20s, even or early 20s, who is now being incubated and is now a part of the family business, right? And you're dealing with people that are, say, a little older, who have established, who have accomplished, who know what the ropes are. And there are certain challenges that I don't think I need to spell out for all the psychologists in the room that would exist in this dynamic, right? What geropsychology tries, would say here comes in is because what it does is it tries to help you to look at the older adult for the person that they are, for the experiences that they've accumulated over the years, for the patterns that they may have operated out of, for any undiagnosed conditions. Because let's imagine, let's understand it today, the people that are aging are 50, 60, 70. How many of these do you think have an ADHD diagnosis? right? Or how many of these do you think have lived with depression for 50, 60, 70 years? How many of these have lived with other mental health conditions, right? Which may be right under the radar. There may have been trauma. They have seen wars. They have seen blackouts. They have seen partition for a lot of them. Stuff that we have not seen, right? So this is all unaddressed. So first addressing these things, even if in the absence of all of this, by the time a person is 60 and 70, there is a complex personality that is developed, not just from their lived experiences, which obviously are a very big part, but also from, the family systems, for instance, or their own comorbidities, for instance. So all of that today, this is what science also tells us, right? It's all tied up. And that's what I think is a lens that is needed. Of course, in this particular case, it is not just a geropsychologist that will be able to step in here, and you will need two kinds of psychologists at least in that room, and preferably one that has and works with family systems and relationships. But yes, that's the part that geropsychology can contribute to here. I hope that answers your question.
Hello. Hi. So this question is to anyone who is a mental health professional on the panel. I am a practicing psychologist, as I think most of us are, and I just wanted to understand what can be a follow-up training, because I've done my master's a lot of time ago. I think it's been quite many years. So what can be a training or a workshop to look forward to which can help us educate ourselves?
Sure. I'm guessing I'm taking this one. May I know your name, please?
Prachi Naik.
Prachi. Okay. Hi, Prachi. So I have both good news and bad news. Okay. So there are a bunch of small trainings that you can take. There are certain allied courses that deal more with gerontology are there. I think TIS does one as well, right? Which you can take. But that integration and the critical thinking of what you've learned in your psychology masters versus what the gerontology course offers you is something that you will have to do in your head at this point, okay? From a formal perspective, that is what is there. From an informal certificate courses perspective, we run courses on geropsychology, which are for practicing therapists. So you can look us up, Tanvi Malia's Elder Care Services on Instagram. And that's where we post like a lot of these courses. We're also, as Geetika very kindly announced in my introduction, we're in the process of formalizing the field. Even in the US today, there are only 4 universities that offer a PhD in geropsychology. That's how new this field is in the world. Okay, so we're in the process of announcing a formal course next year, and it's with a very prestigious set of universities. So hopefully you all will see that, and that will be another way, and we're hoping that we don't stop there and this continues. What I would, however, like to say is if you are keen on practicing with older adults, whether it is in a therapeutic interventional space or whether it is in a clinical diagnostic space, what is more effective at this point, considering we don't have a wide variety of courses, is practical experience. So, work with centers, not just that have elderly, but work with neuropsychologists and psychologists and therapeutic professionals wherein you will learn these skills, okay? Because like I keep saying, it's not simply about going there and doing 4 activities and coming back, okay? It is not also about just sitting to them and talking to them like you are their friend. There's a lot of science, there is a lot of proper therapeutic interventional skill and strategy that has to go on behind the screens. Okay, I hope that answers your question.
And we have one last question though. And because we are running out of time, I'll just take one last. Yeah.
Just the couple of them, I'll just try and club them together. One thing that I have often observed while working with the older population, and since we were talking about the preventive care, and in fact amongst some family members, is aging also involves a lot of bereavement and a lot of grief, because it takes away a lot of things from those people. So, and many a times when it comes to kind of approach, even suggesting them that, maybe talking to someone would help, or have you considered, there is no acceptance towards that. And basically, many a times it is seen that they like to defend the fort until the end. Like, no, we are not doing it. We don't need any support. We are strong. So the question is that is grief and bereavement work also like considered to be a significant part of Gero training?
Yes, it absolutely is. In fact, and which is why I think this is something that has largely been unaddressed through the panel. The topic is beyond memory loss, right? And a lot of the conversation today has been about dementia and carers and all of that. But aging is more than memory loss. Not everybody gets dementia. Significant chunk do get, and it's undiagnosed. So let's underscore that. But grieving or bereavement is a part for every individual as they age. It is not just, so typically when you talk about this, you would think about, losing out, the emptiness syndrome, right? With families moving, with children moving away. You would think of the grief of maybe losing out on their closest friends, losing out on their own physical capabilities, their own cognitive capabilities. There is insight present, even if initially, as Dr. Aditya was talking about cognitive reserve, when the individual has cognitive reserve, but they notice that their cognitive effort is increasing in certain things which were very easy before, suddenly are now taking more time. Right? This comes in way before it will show on your MMSC or your, other neuropsychological test batteries, right? But when this starts happening, the person is aware. There is that insight present, right? So they're also grieving that. But more importantly, one of the things that nobody talks about or talks about very little is the grieving that comes with retirement. Right? Nobody talks about this. There is a lot of loneliness, and usually, and this is something that I feel as a country, we need to fix at a systemic policy level wherein we don't have retirement policies in place. They're not very mental health inclusive. And I'm hoping that will change, because now 2 years ago, Google had a happiness officer, so who knows, right? But so I think these are very important questions to address. In addition to cognitive stimulation therapy, which has largely been spoken about in this panel, there are many other therapeutic modalities that are used within the geropsychological space, a lot of which you all already learn. You all just need to learn how to use them with elderly. Right? So I hope that answers your question.
This is a quick add to that. See, in a Christ University, we started neuropsychology program 5 years back. Now there's a 5th batch. When we structured this program, we thought that those who complete this program, they're going to work in the geriatric unit or the daycare center. That's how we visualized. Now we see there is a huge gap. What is a gap? I see in that some of the students, they don't have that skill to listen, to skill to work this population. It's not an easy population to work. When you work with them, there's a lot of things that happens within them. They also need to be managed well. That is one thing. Another thing, this population has a lot of comorbidity. They may suffering diabetes, they may suffering with, high blood pressure, they may suffering epilepsy. Like this, when you have this comorbidity, it's a very, very essential. You need to understand other team members' approaches. I'll give one best example. Last week, one of my students, she went for the neuropsychological assessment. They come up neuropsychological assessment, there is a moderate memory deficit. Then she went to that report with the neurologist, he is not agreed. Then we look into that patient recently added the anti-epileptics. See, the deficit what we seen in this assessment is a drug induced, nothing to do with the pathology. What I'm trying to say here, this specialization, it's not possible to work in isolated places. You need to be a very good team member, open to learn their approaches. Now totally I changed my approach. My student is to know, how to work with the community, how to work with the family, and also our family system. And also they need to be very good in the, to be a good listener. Now, when you see that we made a different track now. First year, there is a core competencies in neuropsychology. And the second year, they need to work in the dementia and this care unit. I think that is very, very essential. Otherwise, there's going to be the huge gap. What we are, trying this program and what really is expected on the field. Thank you.
Thank you so much everybody for that insight. I'm so sorry, Prasad. We're just running way too much out of time.
But you can catch us after and you can ask us your questions. Happy to.
Yeah.
I think I'm audible, loud enough. Like you just mentioned, you need to bridge the gap. I see a lot of rise in gerophobia.
Yeah.
It's also
Yeah.
because of a lot of people see these people suffering, and community and society is not geriatric friendly.
Yeah.
For example, you go to a mall, you don't even see a ramp. Where probably it's, if geriatric, if they are of the age, probably they say 60 years ka ho gaya, sakya gaya. When it comes to dementia, there are some probably reversible, but for example, Alzheimer's, I think it's progressive, so it is not reversible. But people who are the carers need to be, with those people, and I see increase in gerophobia with youngsters in the same family because they see their elderly suffering. So what do you have to say about, and we also see products like anti-aging, not pro-aging. So these things are creating, gerophobic population. So what do you have to say to that?
Ma'am, I can only say that the course that I designed and I teach at Xavier's, the first chapter that I've designed and we teach is exactly this. We teach them about ageist attitudes, ageist societies, how that influences our view on aging, how that actually creates an impediment to diagnosis and diagnosis at the right time, because a lot of the symptoms, coming back to neurodegenerative conditions, are normalized as a part of normal aging. You know what Dr. Aditya spoke about, the masking behaviors from the family, but even if the family notices, right, they notice certain forgetting. They say, abhi to umar ho gayi hai na, ye to hona hi hai. Okay, so until the person actually starts forgetting the family members' names, etc., then we see that. And this is the first chapter that we start the masters. I don't know if there are any lifespan counseling students here. Yes, so you know what I'm talking about. That is the first thing that we start. That is the first sensitization that we start with. So I absolutely agree, and it has larger ramifications than what you just mentioned. Yeah, I hope there are more universities that incorporate neuropsychological training.
Yeah, that's very important. I think one of the epochs that play a very important role is the retirement that you rightly pointed out. And I keep saying this, that 60 and retiring from office does not give you the license to start forgetting things. I mean, please, that's just a casual conversation that we are 60 and now we have the license to forget things. No, you don't. So thank you so much for that insight. We can keep going on and on about this for another 3 days because there's a lot to talk about this, but I'm just happy that we are at least beginning to have a conversation around the process of aging, the normal process of aging, the not normal process of aging, and being sensitive around it. Thank you so much. We can have the certificates and good evening.
Just one quick thing. Geetika, thank you for a wonderful moderation. I think you deserve a very big round of applause, and thank you as well. And all of you, thank you for being a lovely audience, because I've rarely been in rooms with so many mental health professionals where so many hands go up for neuropsychology. So we're all rooting for you. We need more of you all.